Hi, I'm Kendrick Johnson, and I'm a third-year medical student at Touro University. Today I'm going to talk for a second about valve disease. So the content of this is directed towards third and fourth year medical students who are studying for the boards and the wards, and it is intended to be a review and not to take place of studying a textbook. So valve diseases, anything that goes wrong with a valve could be considered a valve disease. But most often when we talk about valvular diseases, we're talking about prolapse and regurgitation. So this can happen in any of the four valves of the heart. We're going to talk specifically about mitral valve prolapse and regurg, mitral stenosis, aortic regurg, aortic stenosis, and just touch on tricuspid and pulmonary valve disease. Endocarditis I had on this list, but I'm not going to talk about it specifically. Just remember that with almost any of these diseases, endocarditis can be a precipitating factor. So when somebody comes into the office and we do a physical exam, we auscultate at the four traditional points for auscultation of the heart. On the right side, below the second rib, right next to the sternum, we have the aortic valve listening post. Just across from that we have pulmonic. And then down, if you go under the fifth rib, next to the sternum on the left, then you have the tricuspid valve listening post. And then also underneath the fifth rib, but closer to the nipple, some people say mid-clavicular line, you have the mitral valve listening post. So this is going to be relevant especially on a test where they're asking you to identify a murmur or identify a disease based on a murmur, or at least using a murmur. So aortic pathology, at least for a test, is going to be found at the aortic listening spot, and et cetera, et cetera. So though that might not be as clinically useful in real life, because in real life we're going to be using an echo to diagnose all of these, that may be useful on the board. So at the aortic listening post, if you hear a systolic murmur, then you got to think about what's happening at the aortic valve during systole. So during systole, the aortic valve is there's a lot of blood going through the aortic valve during systole, because that's when we're pumping. So if you have a murmur during systole at the aortic listening spot, then we've got some kind of a stenosis, because it's making noise when it's going through the valve. So, and then if you have a noise during diastole, well, you know there's not really supposed to be anything going through the valve during diastole, so it's going to be a regurgitation. And that goes for the other valves as well. And on board questions, that can be pretty much all you need to diagnose it. But like I say, in real life, you're probably going to hear something. You may not be able to spot to tell exactly which spot it's loudest. Then you're going to do an echocardiogram and make the diagnosis that way. So mitral valve prolapse is a pretty common one. A lot of people say that this is something you see in young women, primarily thin young women. The statistics don't really support that. It's going to be equal in young men and women. But it's usually an incidental finding because it's most often asymptomatic. But these people can have some symptoms. They can have a little bit of shortness of breath, even some chest pain. But most of the time you probably just find it with the stethoscope. So what does it sound like? I tried to recreate a little diagram here of what it sounds like. Really ought to go on YouTube and just search for mitral valve prolapse murmur. There's a few good videos. I tried to find the best ones, and I really wanted to paste them into this video, but I couldn't really find a good source to do that. but it's easy enough to go on and just search for mitral valve prolapse, and then you'll be able to hear that mid-systolic click, and sometimes with a late systolic murmur if there's going to be regurgitation. In a lot of these, though, there's no regurg, so you won't hear that late systolic murmur. And if you do, then you're probably getting into a more symptomatic case of mitral valve prolapse. So you diagnose this with clinical findings and confirm it with an echo. Like I say, since it's asymptomatic in most cases, it's probably just going to be an incidental finding, and you may or may not get an echo to make sure. And you don't need to treat it. Most of the time it's going to not have any problems, but later on you might have to treat it if it ends up with a serious regurgitation, which we'll talk about now. So the main causes of mitral valve regurgitation are mitral valve prolapse, like we just talked about, rheumatic fever, papillary muscle dysfunction, and endocarditis. And if you don't do anything about it, you can just picture the left atrium is going to have an increase of pressure. So the mitral valve is the valve between the left atrium and the left ventricle. If that valve is leaky, then every time you squeeze the left ventricle, you're going to get regurgitation back up into the atrium. So that's going to have an increase of pressure in the atrium, and that can cause dilation, and then we back up that pressure even further into the lungs, and you get pulmonary edema. So if that's not kept in check, then you could end up getting some serious pulmonary edema and eventually cor pulmonale. So it's something you want to make sure you take care of. It's going to sound like a high-pitched apical holosystolic murmur radiating to the axilla. So when I say apical holosystolic murmur, remember back at the listening posts, that little M is down at the apex of the heart. That's where you hear most mitral pathology. So you also get a laterally displaced PMI, and this is going to be, again, confirmed with echo, which all of these will be. I might stop talking about the diagnosis because in all of them you're going to confirm with echo. And in order to treat it, ACE inhibitors, vasodilators, diuretics, and surgery. So the main idea is if you've got this extra pressure going backwards, if we can reduce the systemic pressure, then more of that is going to go out through the aorta instead of back up into the atrium. So ACE inhibitors and vasodilators and diuretics all serve that purpose. In some cases, we do surgery, which could include narrowing the opening, so we get less blood seeping back through into the atrium. Mitral stenosis is primarily caused by rheumatic fever, and this used to be more common when we had more cases of rheumatic fever. Rheumatic fever used to be the number one cause of valve problems, but it isn't any longer because we found antibiotics. So the complications that can come from this are left atrial involvement. So this is a little bit different than the left atrial enlargement that we saw with mitral regurg, because now we have an increase of pressure butting up against that mitral valve. So it's harder for blood to get down into the left atrium. So we've got the right heart pumping blood through the lungs and into that left atrium, and it's not getting into it's not getting into the left ventricle as quickly as it should. So following that same logic, you get right heart failure because the right heart is having to work harder in order to get the blood where it needs to go. So with these people, you see shortness of breath, you see orthopnea. In some cases, you get hemoptysis because of the pulmonary hypertension, and of course you get pulmonary edema. Atrial fibrillation comes with any time that you're going to enlarge the atrium. So we could have seen that with the mitral regurg as well. So for treatment, I'm going to be honest here and say that I'm not quite sure about this. I read the up-to-date article because in the review material I was looking at, it said to never give inotropes. But I've always understood digoxin to be an inotrope. So it lists in the review material that you give beta blockers, digoxin, anticoagulants, and valve replacement. So the beta blockers you can, of course, understand for the same reason we just talked about. If we are able to decrease the amount of work that the heart has to do, then you'll get less heart failure. And the digoxin, I actually don't really understand how that would fit. Anticoagulants, because you can get clotting around the stenosis. With any of these, you can get blood clots. And valve replacement, of course, to create a valve that works better. And then, of course, if you do a valve replacement, then you for sure anticoagulate for life because there's a severe clotting risk there. And to take a look at what it's going to sound like. So if it's a mitral stenosis, that means that the little opening going from the left atrium to the left ventricle is going to be narrow. So when does blood go through that? Well, it goes through during diastole. That's when you're filling the left ventricle. So if that process is slowed down, or if you have a narrow opening, that's when you hear the murmur, and that's going to be happening during diastole. So aortic regurg can be caused by endocarditis, rheumatic fever, ventricular septal defect, congenital bicuspid aorta. This is one of the ones that you will see appearing later in life if you have a congenital bicuspid aorta, which also can result in aortic stenosis. Tertiary syphilis can cause this, as well as aortic dissection and Marfan's, as well as trauma. So lots of things can cause this, but the overlying idea is that we are losing the effectiveness of the valve to close. So you can understand endocarditis, rheumatic fever. We're disrupting the leaflets there of the valve. Marfan syndrome, you get aortic root dilation. So you end up having a bigger hole, but not more valve in order to cover the hole. So the main idea is just that we don't have a valve that closes. This is the one that is classically associated with some pretty interesting findings. I'm going to pull out my cheat sheet here because I don't remember what all these different eponyms are. Give me 1 second to pull that out. But the main feature here is that you have to push real hard to counteract this aortic regurgitation, because you're going to squirt all the blood up, and then it's just going to fall back down in to the left ventricle. So you get these characteristic findings, like the water hammer pulse. It's characterized by a wide pulse pressure. Again, you have to really squirt a bunch of water or a bunch of blood up into the aorta, and a lot of it's going to drip back down, so you have a big difference between your systolic pressure and your diastolic pressure. There's a Traub sign, which is a pistol shot bruit over the femoral pulse. So you hear just a lot of blood squirting by when you're listening to the femoral artery. Corrigan's pulse is an unusually large carotid pulsation. So you'll be able to see the carotid pulse. Quincke sign is a pulsatile blanching and reddening of fingernails upon light pressure. So, when we blanch the fingernails to check for capillary refill, if we just give a light pressure on the end of the finger, then you can see blood kind of squirting into the fingertips there. Demusset sign, I'm not sure how that one's supposed to be pronounced, but that's the head bobbing, where the carotid pulse is so vigorous that you see people's head bob due to the pressure. And then, let's see, Muller's sign is pulsatile bobbing of the uvula. So you look in the mouth and you can see their little hangy ball jumping up and down. And de Rosie's sign is a to and fro murmur over the femoral artery. It's heard best with mild pressure applied to the artery. So you diagnose this as the same way as you do all the others with an echo, and then you treat it by decreasing afterload. So ACE inhibitors and vasodilators. I think we've said that on all of these so far, that basically if we decrease afterload, then we're gonna be able to avoid some of the symptoms of valve disease. You also do antibiotic prophylaxis before you do any kind of a dental procedure or surgery. So the reason for this is because you have a valve that's compromised and it's susceptible to infection. And then you do a valve replacement in the serious cases. And in fact, probably more often than not, you're gonna want a valve disease with aortic regurg. So the opposite of aortic regurgitation is aortic stenosis, and this can be congenital rheumatic fever, or it can also be just associated with age. I mentioned before the bicuspid aortic valves. Those are tend to get calcified and lead to aortic stenosis with age. So there's a classic triad associated with the aortic stenosis: syncope, angina, and exertional dyspnea. So that's the classic triad, quote unquote. It sounds to me a lot like an MI as well. So syncope and angina with a history of exertional dyspnea. That sounds like an MI too. So these people are going to get the full workup anyway, but this is the classic triad for aortic stenosis. So the treatment is basically surgery. There are other options, but they're mostly just when you have a poor surgical candidate. So you can do a mechanical valve, or you can do a bioprosthesis. You could do like a pig valve. And I don't know the benefits to one or the other. Personally, I'd go for the pig valve. That sounds cooler. A poor surgical candidate might get a balloon valvuloplasty. If you got a constriction of the valve, it makes sense to stick a balloon up there and inflate it, and so the valve gets stretched out. Endocarditis prophylaxis, again, because we've got a spot where infection likes to grow. And then this says never give beta blockers to aortic stenosis patients. So these people are working pretty hard already just to get the blood out to the body. And so if you give a beta blocker, you're going to slow down the heart as well as decrease contractility of the heart. And they're not going to get enough blood out to their brain, kidneys, etc. so these people can go into shock if you give them a beta blocker. And as you can imagine, in aortic stenosis, the aortic valve has blood going through it during systole, and so if it's stenosed, then you get a pretty loud sound, pretty loud murmur all throughout systole. Oh, I forgot I was gonna make my own heart sounds for you. So this would be a whoosh, 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 whoosh. You probably aren't gonna hear S1 and S2 because the murmur is pretty loud. This is just a note on tricuspid and pulmonary valve disease. They both can be caused by carcinoid syndrome. They both can be caused by endocarditis. When we think about tricuspid valve disease, we often think about IV drug abusers because they're sticking stuff into their veins, and that's going first to the tricuspid valve is going to be the first valve that those little disease-causing pathogens are going to hit. Generally, it's going to be Staph aureus, Staph epidermidis, causing the endocarditis in the tricuspid valve. But carcinoid syndrome also causes a fibrosis of both of these valves. Tricuspid stenosis, you hear a diastolic rumble. Tricuspid regurg is holosystolic, and look for jugular systolic pulsation. So I didn't mean to skip over. With tricuspid stenosis, it sounds a lot like a mitral stenosis. Again, we're doing these valves are kind of acting at the same time, and so they're going to sound like each other if one or the other of them sounds like stenosis. Sorry, if one of the other one has a murmur. But the tricuspid stenosis is going to be louder in inspiration. So if you think about that, when you take a deep breath, you are decreasing the pressure. Just kidding. It doesn't really make sense to me. So you can think about that on your own. Pulmonary regurg, you get the Graham-Steele murmur, which is just a diastolic murmur at the left sternal border. Remember, the left sternal border, fifth intercostal space. This second intercostal space is the pulmonary listing spot. With these, you can do balloon valvuloplasties. It's rare to do a valve replacement on either the tricuspid or pulmonary valves. So the pictures of the murmurs were taken from Wikipedia. There's a Creative Commons license on them. But please give me your comments on the video. Again, it's intended for medical students studying for the boards. So if there's anything important that you think I left out or any problems, errors, please leave a comment or send me an email at kendrick@themedschool.com. Thanks.